I am going to be talking about depression in primary care today, and this is an abbreviated version of a noon conference that Lindsay and I gave earlier in the year, so if it sounds familiar, that's probably why. My main goal today is to talk not about the specific diagnostic criteria for depression. I'm assuming that you all are pretty familiar with that. But something that the DSM doesn't do a great job of, in my opinion, is kind of differentiating the different levels of depression. So I'm going to be talking about the continuum of depression and how you can identify your patients at each level and what kind of treatment would be most beneficial, when to involve behavioral health, that kind of thing. So if we think about depression on a continuum, at one end of the continuum we have what we call transient depression, and this is um, really not clinical depression at all. This is the kind of normal emotional experience that we expect for human beings to have. You know, we're not happy all the time, and sadness is part of that emotional range that is appropriate for people to show. So this is when people might say that they're feeling blue. It can involve everyday problems. Typically, we expect patients in this transient depression category to score between 0 and 9 on the PHQ-9. So they're not at a level that reaches significance, clinical significance. If patients are in this area, if they request to be referred to behavioral health, that's definitely fine. But there are a lot of things that you as physicians can do in those appointments that you really don't need us to help with. And these kind of interventions will help to resolve the transient depression pretty quickly. Transient depression typically resolves on its own, and if it doesn't, then it's probably not actually transient depression. So these kind of baseline interventions would be things that would be helpful for anyone. So psychoeducation about what this person is experiencing, that it's a normal part of being a human, it's a typical experience. And then kind of these baseline interventions for things that will make anybody feel better. Things like increasing physical activity, maintaining a nutritious diet, looking at sleep hygiene, leaning on social support, things like that. That will be kind of the foundation for all of the interventions that we would give anybody with depression anyway, so they can help transient depression resolve sooner. When we get into the levels of clinical significance, then just next door to transient depression is mild depression. These are folks who would probably score between a 10 and a 14 on the PHQ-9 as a general rule. And these people start to show physical, mental, and emotional symptoms of depression. So physical signs, this would be things like general pain, headaches, fatigue, insomnia, appetite disturbances, things like that. Mentally, we start to see cognitive changes at this point. These people would have difficulty concentrating, probably limited insight into their own functioning, possibly some memory disturbances. Especially in older populations, we can see this as pseudo-dementia, actually, that older populations will start to have more of these cognitive disturbances, but the key between pseudo-dementia, that's actually depression, and actual dementia is that these older individuals typically have more insight into their memory problems. They might come to you complaining of cognitive or memory problems, where with true dementia, usually it's a caregiver or a loved one, somebody else is letting you know that there are problems. So we've got these physical, mental, and emotional symptoms. The emotional symptoms are ones that we're very familiar with: feeling down, sad, apathetic. Irritability is a big one when we get into the clinical levels of depression, and we tend to see irritability more in children and in middle-aged to older men. So for children, we see that irritability is just one of the symptoms of depression, but it can also stem from not having the language to express the emotional experience that they're having, which can be really frustrating and increase irritability. In men, we see irritability and depression. The theory is that it is more socially acceptable in our culture generally for men to express anger or frustration or irritability than it is for them to express sadness. So this might be a safer way for them to let somebody know that they're not doing okay, is if they're irritable. Individuals with mild depression might feel like they're going through the motions. Um, this depression typically isn't getting in the way of everyday functioning. These people are still able to care for their own hygiene. They're able to go to work typically and make appointments, but they're probably not doing much outside of that. They're probably not signing up for social functions, going out on the weekends, things like that. The cartoon character that we chose for this, if it helps to conceptualize that way, is Charlie Brown. He is around friends, but he has some of this kind of, I don't know, almost existential kind of, things are okay, but they're not great. So for treatment with mild depression, again, a referral to behavioral health is definitely appropriate if the patient is interested in that, but it's not necessary at this point. Mild depression can be managed generally pretty well with medications if the patient is open to that, or therapy. This is definitely an appropriate referral. In counseling, what we would focus on with these patients, building on those kind of foundational interventions of nutrition, exercise, sleep hygiene, social support. We would focus on building that therapeutic alliance with the patient pretty quickly and using empathy to do that as efficiently as possible. So being able to identify those emotions that they're feeling and actually elicit some of those emotions in ourselves so that we can relate to them in the room. We also might focus on gratitude journaling with these patients. One of the cognitive aspects of depression is that it puts a veil over everything, and depression makes it just cognitively easier to focus on the negatives, to see everything that's going wrong, and it makes it really, really hard to see positive aspects of life, things that you're grateful for. So gratitude journaling is a good intervention starting at this mild depression category. That might be something that we'll do with them. Behavioral activation is another good one that we might start here at this mild depression category, where motivation is one of the key symptoms of depression, right? Lack of motivation. And so assigning behavioral activation interventions that aren't dependent on patient motivation, where we say this is just part of your treatment. You need to spend at least 15 minutes engaging in one of your coping mechanisms, just like you need to take your pills in the morning or whatever it is. That can sometimes help to bypass that lack of motivation and build up some momentum for the patients to feel better. So that's mild depression. Increasing one step from the mild depression, we get to moderate depression, and these people would likely score between 15 and 19 on the PHQ-9. These are people who are struggling just to kind of do the bare minimum. Again, they are likely able to still engage in basic self-care. They're still probably getting out of bed and showering, getting dressed, probably eating meals, things like that. But we start to see depression cause more functional impairments at this stage. These people might miss work fairly regularly because of their depression. They might really struggle to make appointments. We'll see a higher no-show rate starting in the moderate depression category here. We also see that these individuals are more likely to start endorsing some passive suicidal ideation. And so at moderate depression, we really do strongly encourage behavioral health referral at this point. So even if patients aren't necessarily excited about that, we would really like you all to strongly, strongly encourage a warm handoff here. At this point, medication is likely going to be part of these people's treatment. And this is where we start to really see a good bang for your buck with some combined treatments, so medication and behavioral health. Suicidal screenings for these patients should be a routine part of care because of that passive suicidal ideation. And for these patients, what we would be doing, we might start some cognitive behavioral therapy, focusing on that thought, emotion, action chain, and looking at the maladaptive thoughts that might be contributing to their depression. So to that end, we might assign them things like thought logs where they can keep track of distressing or overwhelming thoughts throughout the day. We'll also be safety planning with these patients, so identifying risks and warning signs for suicidal ideation, red flags that they can notice, inventorying coping mechanisms that they can do to help manage that suicidal ideation on their own, explicitly listing different people in their support systems that they should call, all the way up until coming into the hospital if they aren't able to manage those suicidal thoughts. Okay, then after moderate depression, and with moderate depression, we chose Eeyore in our presentation. Eeyore is, he's functioning. It's all that he can do to keep his tail on and his house together, and sometimes that doesn't go well either. So that's why we chose Eeyore. He's kind of doing the bare minimum to get by. And then we've got severe depression. So these people would score probably 20 or over on the PHQ-9 if they're answering honestly. This is when depression really becomes debilitating. Andrew Solomon wrote a really good book called The Noonday Demon that does a really great job of describing severe depression from the inside. That Andrew Solomon is a reporter who experienced severe depression for years, and he talks about how debilitating that was for him. So these are people who might not be able to get out of bed. Their motivation might be that sapped. They are likely not able to go to work. They are definitely not doing anything extra, no social activities. And they will probably have a very high no-show rate for your appointments. This is definitely a population where a behavioral health referral is absolutely necessary. These patients, even if they don't want to see somebody from behavioral health, they really, really need to. A big part of that is because they are likely experiencing at least passive suicidal ideation, but it's a good chance that they might be experiencing active suicidal ideation as well. And if they aren't currently, then there's a good chance that they will in the future. So safety planning is an absolute must for these patients. It's really important that they know what to do if and when they do experience that active suicidal ideation, what they need to go through, the steps that they need to go through on their own with their support network, and then finally with professionals in the emergency department. It's very likely that these individuals will undergo hospitalization for depression at some point for their suicidal ideation, and so it can be helpful to talk ahead of time with these patients about what that might look like and what to expect. Again, just like in moderate depression, this is combined treatment is very, very appropriate for individuals in the severe depression category. So we're looking at medication and behavioral health referrals. So that's kind of the continuum of depression from, very normal transient depression that everybody experiences from time to time, all the way up to severe depression that might involve some active suicidal ideation. The fictional representation that we chose for severe depression is Dementors from Harry Potter. J.K. Rowling famously was experiencing or had a history of depression, and so these shadowy figures of death that come and try to suck the joy out of everything that the characters are doing, that she based those off of her experience with depression. So if that helps to kind of conceptualize it. So yeah, that's kind of the continuum that we have when behavioral health definitely needs to be involved, and what we would be doing with your patients and what you can be doing with your patients as well.